Okay.
How long have you been married? Now that's under recording.
Good evening, everyone. I'm Clare Crawford, and I am a health information management student at Tacoma Community College. And I am studying health information management as part of a AA degree. And I do hope to obtain my professional qualification, which is an RHIT, sometime by the end of May. So as I'm in my final quarter, so one of the requirements of that final quarter was for me to write a research paper. And my topic of choice was clinical documentation improvement and its effects on medical reimbursement. So why did I choose this particular topic? Well, I used to work at KGH, now Trios, and I became acutely aware of the difference in the levels of documentation that physicians would give us to analyse. So I decided to zoom in on this topic, and so we're going to look at medical reimbursement in the inpatient setting. So, what drives medical reimbursement in the inpatient setting? It is the MSDRG. So MSDRG stands for Medicare Severity Diagnosis-Related Group. So what does that mean? Well, basically, it's a method of classifying the patient's stay in the facility into one of numerous groups, and that facilitates a reimbursement for the services rendered to the patient. So basically, they are grouping patients with similar characteristics, such as similar diagnoses and similar treatments. And that medical reimbursement is based on the average cost of providing treatment to a patient with a diagnosis of pneumonia and being treated with IV antibiotics. And that's grouped into a certain MSDRG. So how is the MSDRG actually calculated? Well, it actually consists of a number of factors. First factor is the principal diagnosis. And then we have to capture the surgical procedure. The other factor we're looking at are any major complications and comorbidities, or just basic comorbidities. We're also looking at the sex of the patient and the disposition of the patient, whether he's going home, whether he's being transferred to a different facility, whether he died. And the other factor is if the patient was a newborn, we're going to take into account the neonatal birth weight. So these factors are all taken together and they are used to allocate the MSDRG. So where does clinical documentation improvement come into the picture? Well, we're going to look at two physicians, physician A and physician B. And we're going to compare their documentation and what that does to medical reimbursement. So physician A, he is very diligent in his documentation, and he's captured the principal diagnosis, which is an open fracture of the femur. He's not just captured that diagnosis, he's been very specific. He's captured the site of the fracture, maybe it's the head of the femur. He's captured the type of the fracture and the laterality of the fracture. And that's all documented. He's captured the open reduction and internal fixation. And this poor unfortunate patient also has COPD. And he's suffering from an acute exacerbation of the COPD due to the fracture, and this has been actively treated in the facility. And this patient is male. So when all these factors are combined together, we're going to be allocated an MSDRG of 517, and that's a reimbursement rate of $6,918. Now let's have a look if physician B is treating the patient. So he captures the principal diagnosis, which is the open fracture of the femur, but he is non-specific. He's captured the surgical procedure performed, and he's captured that the patient is male, But there's one big factor missing that he hasn't documented, even though he's treating it. And it's this area, the COPD. So that has actually lowered the MSDRG to 482. And he's now only going to get the facility paid to the amount of $6,326. So he's just cost the facility $500 plus, and that's just for one patient. So we can see where clinical documentation improvement is well worth the investment. So what are other areas that may yield higher MSDRGs with just a little bit of extra effort with physician documentation? We're looking at anemia, pneumonia, fractures, cardiac disease, and malignancies, and these are just a few areas. And say we zoom in on pneumonia. We can have a very simple pneumonia, but if that pneumonia, we have to actually document the cause of the pneumonia. Is it a viral pneumonia, bacterial, fungal, aspiration? If it's a bacterial pneumonia, what's the cause? What organism is causing it? If we capture these specific parts of the actual diagnosis, we can increase that MSDRG and get some more reimbursement for the facility. So if the physician just documents simple pneumonia, he's going to have a DRG of 195, and that is associated with an average length of stay of about 3 days. If he gets a higher MSDRG with an average length of stay of 6 days, he's going to get a much higher rate of reimbursement. So I hope that my presentation has shown you the worth of CDI, and if you have any questions, I'm very happy to answer them at the end of the session. Thank you. Any questions? Did I explain it well?
Yes.
Yeah.
I think the thing is that most of us are outpatient coders, so DRGs are unique to them. I teach inpatient coding, so I understood everything you said.
Okay, was I okay?
You did
You were
well.
awesome at it.
Really?
You did well and you speak well too.
Okay.
So you're going to look good